Hey, Sam, how are you?
Hello, Clint. I'm good. How are you?
Well, thank you. So today we are talking about Sever's disease, which I'm trying to remember. It's also called child heel pain. Is that correct?
It's a children's heel pain.
Children's heel pain. Yeah.
Children's heel pain.
So I guess this is an interesting one in that probably most of the people watching are going to more likely to be parents. And so it's going to be parents who are worried about their children. So it's a slightly different context there. And the fact, so I guess, first of all, tell us about why it is. And I guess what I'm most interested in is why it's sort of treated as a separate condition. Is it something about is there something about children that means that they can suffer this where adults can't, or something like that?
Spot on. Yeah.
Right.
It's so Sever's disease is children's heel pain. It's not actually a disease, but it's called Sever's disease.
Mm-hmm.
And what its technical term is calcaneal apophysitis. So
just rolls off the tongue, doesn't it?
It just rolls off the tongue. Yeah. So if we break that down, calcaneal is the calcaneus, so the heel bone. The apophysis is the growth plate, and the itis is inflammation. So
now, when you say growth plate, whereabouts in the foot is this growth plate of which you speak?
This particular growth plate is at the back of the heel. So
right.
If we break that down, the calcaneal apophysitis part is the growth plate inflammation of the heel bone. So
right. And that's why only children can get it, because you got to be growing to have a growth plate. And
exactly.
Understood.
Exactly. Okay. And so that will fuse. Typically, we see this in children as they're growing. We see it typically between the ages of about 8 and 12. Slightly different boys and girls, but around that sort of age group. In particularly mostly in active kids, we're going to get that sort of presentation. And usually it's because that growth plate is still active, especially common after a growth spurt as well.
I was about to ask that, yeah.
Yeah. So very, very, very well defined and very well understood clinical diagnosis. But it's something that's why it's treated differently, because you can't get it as an adult, but you can definitely get it as a child.
So I've never thought to ask this question, and intuitively I assume the growth plates are more susceptible to damage. They're probably not as durable as the rest of our bodies. Is that correct?
Yeah, and typically it's the interface between the growth. So if we looked at a heel bone, for example, in this particular case, now this can happen in the knees as well, can happen in different areas of the foot, but in this particular one, so Sever's disease is particularly the growth plate at the back of the heel. So if we looked at a heel bone, for example, in you and I, if we took an X-ray of our foot, we would have one complete heel bone. If we took an X-ray of a child's foot and looked at their heel bone, it would look like it's broken, or would look like it's in two distinct bones. Now there'd be the main body of the bone, and then there'd be like a little crescent or a smaller section at the back of the bone, which would and so if somebody watching hasn't seen this, it's you can, if you Google an X-ray of a child's heel and you looked at that, you'd see so many different variations. They all look a little bit different, but they're essentially, you're going to see two bones. You're going to see something that if you didn't know what you were looking at, you'd say, well, that's definitely broken. It's not broken. It's the heel bone and the growth plate of the heel bone. And typically it's that interface there that causes the trouble, because if you look at 10 different X-rays, you'll see that, some of them are smooth, that interface is pretty smooth, some are pretty rough. It can look like it's a congruent bone. So it can not look like it's a congruent bone. And that will typically,
in this context, when you say congruent bone, what do we mean by a congruent bone?
So, that the two pieces fit really nicely together. Yep. Now, typically what we're going to see is some sort of, interlocking. It'll be like a roughness in there, rather than like a nice bone. And
that's not an indication of any medical condition or anything like that. No. It's just we're all individuals and we've all got our own interfaces. Gotcha.
Exactly. And that will explain a little bit of why some children will get more pain than others. Some children will get pain, some children won't get pain. That sort of, some children will get pain on the left, not on the right, for example. That sort of thing. It's very individual.
Can you have a different level of congruence from left to right as well?
Yeah, it's different.
How about that?
Different. And you can have different pains, different we're not symmetrical machines as we develop. And you can, typically, you can get pain in both feet. You can get pain in just one side of the body. You can get pain in both feet, but they're equal. You can get pain in both feet, but they're unequal, So
Gotcha.
it just depends on what you're seeing. But typically between those ages, around 7, 8 to about 12, and sometimes extending to 13 or 14
just
even.
depending upon
but in that age group, we've got an open, active growth plate.
Yeah. So to sort of summarize where we're at, it is where the growth plate and the bone meet. That's where the inflammation is caused or is present. And this is why it's only occurring in children, because you need the growth plate and the interface. Common with the growth spurt and also common in active kids. So I guess there's nothing terribly surprising there. We're all sort of expecting that. Now, I'm not sure if we've actually said that or not, but we're basically looking at some kind of a damage or inflammation in that region at the interface. Is that correct?
Inflammation around the growth plate, yeah.
Gotcha.
Yeah.
So given that we know what it is and what's typically caused it, first off, I'd normally ask, how do we treat it? But I guess at this stage, if it was a parent and it's their child, is there anything they should be looking out for? Will their child tell them? Will they notice something about their child when they'll be able to tell this is happening?
Absolutely, the child will tell them.
Right. Okay. It is that painful, yeah?
Yeah. It's pretty sore. And typically how you'd see it present is a child limping. Very, very likely to be limping during or after an activity. So typically we see it at sports, playing football, soccer, things like that, tennis, any other impact sport. Not usually when they're walking, but sometimes. But mostly it's when they try and run or do something. And then what usually will be the presentation is you get pain at the heel, they're limping around or toe walking. So I
was about to ask the kind of limp it is. So they'll probably be putting more or less the same amount of weight on that leg, but it'll be more that they'll be putting the weight to the toe or the ball of the foot as opposed to the heel.
Exactly. Trying to avoid the heel. Or in some cases, they just don't run at all, or they withdraw from the activity or have to come off the field, things like that. So typically it's very noticeable. And so some parents will automatically think it's either sort of plantar fasciitis or it's because they're equating that with the adult analog of the child heel pain, or they'd be worried that they're just being lazy or something like that. If they're why are they not running, or why they're complaining of the heel pain. Sometimes they think it's growing pains as well. Now, very importantly, it's a differentiating sort of thing. Growing pains typically will happen along the shin or along the tibia, and that usually happens at night. It's only about 20 minutes or so. You'd be rubbing at Panadol, that sort of thing there. This one is not a growth pain, but it's growth related, like we're saying. It's related to the growth spurt, related to the growth plate, and commonly after a growth spurt, but it's not a growing pain in its essence. So that's the important differentiator there.
So, right. So that's, your child will probably spot what it is, and you'll also see them limping and such. So I guess the next question then is treatment.
Yeah, so with treatment, I guess it's a very, again, pretty individual, but there are a couple of things here that will work for, I'd say, about 90% of children out there. And that is heel raisers, putting heel raisers in the shoes. So we... so
it's not an exercise. When you said heel raisers, I imagined an exercise.
Not an exercise. They're physical heel raisers that we put in the shoes.
Right.
And so they're like little elevators.
I'm assuming that basically puts their weight on the ball of their foot and puts less strain on the heel. Is that the notion?
Yeah, it takes the strain off it, and it reduces the length of the Achilles tendon, or your calf muscles and Achilles, takes the tension out of that just temporarily. We don't want that. We're not going to rely on that forever, and it's not a good thing to rely on forever, obviously, but it's something that will at the start be part of our treatment program. Definitely, because it's an inflammatory sort of condition. So things like icing will definitely help as well. And like I said before, this is typically going to happen while we're running or during an activity. So it might come in, like, let's say 10 minutes into running or something like that, or, during some sort of, everyone's activity is a bit different. Everyone's weight's a bit different. There are different factors, but typically the three things that will happen here are any movement. So the main thing that's happening here is you're getting some sort of traction or movement between the growth plate and the heel bone and the rest of the heel bone. And like we said, because they don't fit very well together, Any movement around there is going to make it a little bit angry, and that's going to make it inflamed, and that's where you get the pain and the limping. So the initial thing would be impact, hitting the ground, would be a big factor there, because you're hitting the ground, you're introducing a lot of shock through that area. But then, like we were saying before, at a period of growth, so growth spurts where we add some centimeters, we're getting taller really quickly. What happens is the bone will grow first, so the tibia will grow first, and then that places the Achilles tendon and the calf muscles. That makes them effectively a bit tighter now, because they're attaching to the heel bone, around that growth plate area. So if we're getting a lot of tightness around there, a big part of the treatment there is calf stretching, the calf muscle stretching, gastrocs and soleus. We've got two calf muscles there that attach, one deeper down inside, closer to your bone, and then one on the outside, the fleshy part that you can see. Right. And they both attach through the Achilles tendon to that area of the heel. So as we get taller, if we're tight in that area, that's a big part of the treatment would be stretching that.
Gotcha. So it's interesting. I guess I'd never considered this, but this is another reason for, they always say for just in general, you should, sort of stretch before you exercise, something like that, just help you warm up. But with children, I guess there's that extra motivation again for stretching, and that is that kids go through growth spurts and they could end up being a bit tight because of that. And so I guess generally speaking, a number of conditions that children could face could be reduced in likelihood simply by keeping themselves flexible. Getting ready for that growth spurt. That's a very interesting piece of information that I've never had before. Okay. Yeah. That one's saying that's very interesting.
So that's where the heel, no worries. Yeah. That's where the heel raises sort of, sort of, give you a bit of context there. That's why that would, but again, it's as we're stretching going through a treatment program, which stretching will absolutely be part of that for most kids. The heel raises are there because the stretching doesn't happen overnight. The lengthening and the adaptation you're going to get doesn't happen overnight. So usually we have heel raises that one of the benefits of the heel raises is reducing that sort of tension on the heel, but it changes the moments around your foot as well.
But I guess that's coming back to what I was saying. I push my own wheelbarrow here. Anybody who's running any kind of children's physical activity, it's a smart move to have stretching and flexibility as a part of that, just because they're kids, and just to keep them flexible so that they're ready for that growth spurt when it kicks in.
Absolutely.
Yeah. Okay. So getting back to treatment. We've mentioned a few different things there. Parents would have a fairly good idea if their kids do have it, and they'll know why. Is there anything else to treatment that we should be aware of? From the sounds of it, we don't necessarily need to reduce the physical activity that much. It's sort of more a case of just trying to limit the impact on the heel.
Yes.
And the tension on the heel from the Achilles.
Yeah, I think if to sort of put it in to wrap up the treatment part of it, it really comes down to, which will come back to your point in a second. It really comes down to the heel raises definitely being a part of it initially, and icing because it's inflammatory. So definitely coming back to the hallmarks of any inflammatory condition, and then we want to introduce some icing. So the only other thing that sometimes foot posture is related as well, we can then, for some people, we need to go down the path of insoles or arch supports, orthotics, that sort of thing. So shoes with a bit of cushioning, definitely a good thing, and reducing that impact, like we're saying. But I think in terms of the treatment part, it's those are the three things, and with the three things. So summarize those three things again. Or that's just
the
icing, heel raises, and potentially orthotics, shoes.
Gotcha.
That sort of thing. So those are the three things that we'd sort of look to fit around the child's context. But coming back to what you were saying, activity modification is only really necessary, or activity withdrawal is only really necessary in extreme conditions. So extreme cases where we absolutely everyone's pain tolerance is a bit different as well, and things like that, and the different levels of training, different weights of the children, all that sort of plays a part. And so some children will have pain, some children will have reduced pain, some children will have no pain with these treatments. The main thing is what we're trying to do is not close the growth. We're not going to close the growth plate. We're not going to fix the problem. The problem is self-limiting, so it will go away by itself. What we're trying to do, though, is not say, okay, well, between the ages of 9 and 12, your child can't run, can't do that sort of thing. So absolutely, we don't want to do that. All we're trying to do with these measures is trying to get the child to a point where they can still participate in their chosen activity, and they might have a little bit of pain, if it's still, because the thing's still there, the condition's still there. All we're trying to do is limit the manifestation of the symptoms so that they can still play. Now, in some cases, does that mean that you might come off 5 minutes earlier each quarter or something like that from football, if you and ice your foot? That can happen as well for some kids. But as long as we're getting them to the point where they're not limping around and causing other damage, they're able to participate in their sport and get the psychosocial activity benefits as well, then that's the main treatment outcomes that we're looking
Now, I heard a word there, or two words there. It was other conditions. So I'm assuming in itself, Sever's disease is not is something to be too concerned about. But if it's left untreated or it goes too far, it can cause other conditions. Is that correct?
Yeah, it can lead to.
So we do need to treat. If we need to take this reasonably seriously, then.
Yes. Otherwise, children just won't. They won't be able to play in their chosen sport. Then they're obviously you've got the issues related to that if we're withdrawing from activity. But also if it's not treated, and for example, you're trying to avoid weight bearing on your heel, most people will then start toe walking or right, not trying to land on their heel, not trying to put the heel in contact with the ground. Now that's going to lead to other things, obviously, because we've got compensatory mechanisms in our body, and now we're putting force where it shouldn't be. Where we're making the calves even tighter because we're toe walking, and trying to limit that activity or the lengthening there, which will then make the severs a bit worse because now we're introducing an element of tightness there. So, and then all the other things that go with that, then we could start getting plantar fascial pain, or we can get stress fractures, and we can get knee pain, and we can get all those other things that will happen because if we're still trying to participate in an activity and we can't do it in our body's normal path of least resistance way, and we're trying to force it to do a different activity, or we're trying to force it to do the activity a different way, then we're opening ourselves up to different pains. And that's when people usually come in and they say, okay, well, I've been doing this and this and this because of the heel pain, and now I've got this pain and that pain and that pain. And we don't want that sort of thing. So it's very easily treatable. And in most cases, in almost 100% of cases, you're going to get some sort of resolution. Like I said, to different extents. Some people will have no pain at all, and some people might still have a little bit of pain, but it's manageable. And that's really the key word, that we want to get it to a manageable state. And we do that in whichever way we need to do around that until it goes away by itself, which is fantastic news.
So it's kind of like you've got to ride it out in a sense. And we can ride it out with things like, I think you mentioned ice, heel raises, flexibility, and I think you said maybe some orthotics.
Orthotics, if the foot posture is related, and we need to do that.
Is there anything else there that I might have missed with regards to treatment?
No, it's mainly those are the three main ones.
Done.
We're looking at there.
Excellent. Is there anything else just on the top? I guess on this topic now, because it seems to be a relatively short topic, but I feel as though also we've wrapped it up. Is there any other key points that we might have missed that are worth sharing right now?
The only thing I'd say based on what I'd see in the clinic is most people would come in thinking, like I was saying earlier, thinking that it's a growth pain.
Yes.
So knowing that it's not a growth pain is a good thing to know. The other thing is people might be thinking, okay, well, if I see my child limping around like that and they can't put weight on their heel, they must be fractured or something like that. And they tend to rush off and want to get an X-ray or something like that. And absolutely not necessary for the initial diagnosis. It's very much a clinical diagnosis. But sometimes, we do want to make sure that it's not something that's masquerading as a children's heel pain, as Sever's disease. So sometimes we would, so the thing that I wanted to mention here is that, this is the typical pain with Sever's disease or this children's heel pain that we're talking about. The typical presentation is going to be when we're trying to do some sort of activity like running, playing sport, that sort of thing, when we're active. And when we're saying the pain is coming about after that initial loading. So, we're starting to run or it's during the game. Doesn't matter when it happens, but it's related to that. If it's pain that's not related to any activity, if it's pain that's happening at night, for example, in that area, that's something that we'd want to check out. So that's not your typical presentation.
Very good to know.
So that's the only sort of thing that I'd say, based on what we see in the clinic, is X-ray is not necessary to start with, but definitely if it doesn't fit that sort of presentation that we've just described, where it's child active running, doing some level of activity, pain, and then when they rest, the pain will go away.
Yep.
Because that's the other important part of it, is that it gets angry when it gets inflamed, but then once you've reduced that inflammation, or once you've taken away that activity that's causing it to be angry and inflamed, the pain will go away. So typically after an hour of stopping, for example, we'd go back to normal and you'd have no pain. Walking around is usually not enough to stress this, to bring this condition about. But if we are getting pain that doesn't fit that, or we are getting pain, especially like I was saying, especially pain at night time, then we definitely want to get that checked out.
That's very good to know as well. So with regards to pain management, you do provide pain packs. And what's the URL for that website, Sam?
That's painpacks.com.au, and there's a children's heel pain.
Oh, excellent.
Pain pack. And in terms of pain management, that will include all the stuff we're talking about. So that's all you'd need to really get on the front foot with that. And then if we're still getting pain, like we said, or we're getting pain that doesn't fit that, that's when I'd encourage people to sort of get that checked out.
Gotcha. And you also have a shoe website. If I remember rightly, though, do you accommodate children on that website?
Yeah, the orthotics.
Okay, you do.
Yeah, so it's myorthotics.com.au,
Gotcha.
and there's children's orthotics there.
Excellent.
That would be, like we said, for most people, heel raisers and icing and stretching are what we need.
Yep.
For some people, we need to throw in those arch supports or orthotics may help, and that's where we have that sort of option.
Excellent. Thank you for your time, Sam.
Pleasure.